awesome working with Forrest on kind of developing this and the rest of the collaborators. And I'm a radiation oncologist and really interested in treating brain tumors. And when I got to Mayo Clinic 20 years ago, my collaborator in medical oncology said, like, hey, the blood-brain barrier is disrupted because we have contrast enhancement in all these tumors. And so we don't really need to worry about drug delivery into brain tumors because they're kind of, the barrier is disrupted. And that thinking has really pervaded medical oncology for the last 20 years. And I think kind of a critical assessment of the data as well as data that we've generated through our collaborations would suggest otherwise. And so really that's kind of the reason why I have this MYTHBUSTERS logo is just because there's this myth in oncology and neuro-oncology that the blood-brain barrier is disrupted, therefore we don't need to worry about drug delivery into brain tumors. And probably if you try to convince your mom that you need to worry about drug delivery into brain tumors because there's a blood-brain barrier, she'd say, yeah, that kind of makes sense. You need to probably worry about that. And so I think there's this myth or multiple myths that are kind of continued in oncology. And so really one of the goals of our center in general is to try and break down those myths or try and convince people otherwise, that the blood-brain barrier does really matter. And so that's really the focus of my talk, is really kind of taking a look at some of these myths and what the data are that support or don't support this. And this is a shout out to the MYTHBUSTERS, which is, I think this was their last season last year. I think they were looking for replacements, so if anybody's interested, I'm sure they're still interviewing. So anyways, I think one of the striking things in glioblastoma is the lack of progress. I mean, if you think about melanoma, lung cancer, breast cancer, there's some pretty exciting changes that have happened in the past decade where individualized medicine is becoming a reality, and a lot of these tumors, ALK translocation with crizotinib and other targeted drugs for these specific alterations in lung cancer have really extended survival, and same thing in melanoma. It's the opposite in GBM. So the last advance in clinical medicine for GBM was the addition of temozolomide to radiation therapy, published in 2005. Temozolomide is essentially, an alkylating agent, kind of similar to nitrogen mustard. That's the last thing that we really had that really had any impact. And this is not any kind of targeted therapy. And so why is that? Why has there been this really poor lack of progress? And just to kind of set the clinical stage for you, I'll just kind of review a clinical case. This is a 62-year-old lady who has multiple sclerosis, came into the emergency department with some speech problems and a seizure. Usually when you come into the ER, you want to rule out a bleed or trauma, so they did a non-contrast enhanced CT, which was negative, which is the standard, and then they had an MRI, which gives you much better delineation of any pathology. And this demonstrated this contrast enhancing lesion, so you inject contrast into the vein and it accumulates in particular regions where the blood-brain barrier is disrupted. So this was the contrast enhancing lesion. And then surrounding the contrast enhancing lesion, this is a different sequence. You can see a lot of water. So this is what's called a T2 image, and that really picks up water. So the water in the ventricles of the brain, on the periphery of the brain, and then in the brain tissue itself, you got water there. That's edema or swelling, because you're irritating the brain, and so you have this swelling that happens. So they resected the contrast enhancing lesion. They gave him standard radiation and temozolomide. That's the graph I showed you, just the previous graph. And then 98 weeks after diagnosis, she progresses and dies. And unfortunately, this is the standard scenario. 98 weeks is actually pretty good. So that's 2 years. That's exceeded the median survival, which is usually 12 to 15 months. And so we'll come back to this case and kind of what happened. But one of the things that is different in brain tumors than most other tumors that we treat is there's this thing called the blood-brain barrier. And Bill will talk more about this, and I'm sure this is probably a slide that I took from him, and he probably has this in his slide deck as well. But basically, in all tumors, you have this issue where you have to give the drug, have oral intake, has to get into the bloodstream. But then in brain in particular, it has to get out of the blood into the parenchyma of the brain, and that's really limited by this blood-brain barrier where unlike other regions of the body, the capillaries are completely sealed. They're a sealed tube. There's no fenestrations or holes between the capillary cells. And that forms a physical, and there's also a biochemical barrier that limits drug delivery out of the brain. And so all drugs have to diffuse across lipid bilayers in order to get out into the brain parenchyma. And Bill will talk a little bit more about that. But so as you diffuse through the lipid bilayers, there's a bunch of efflux pumps or drug efflux pumps that are pumping drugs back into the bloodstream. And so some of these efflux pumps are really important for limiting the delivery of drugs into the brain. And so the simplistic model for brain tumors is, we have a contrast-enhancing lesion, therefore the blood-brain barrier is disrupted, so we don't need to worry about it. But on the flip side, 98% of the drugs are excluded from the blood-brain barrier. This is just kind of all-comers, FDA-approved drugs. Essentially 98% of them are effectively excluded from the brain. That's probably a good thing. I mean, the brain is designed to keep toxic chemicals out of your brain because otherwise your brain doesn't work very well. And if the blood-brain barrier is disrupted in all GBMs, then brain penetration is not relevant. But on the flip side, if the blood-brain barrier is intact or partially intact, then it's highly relevant because 98% of the drugs that you might try won't work. So just to go through the myths, the blood-brain barrier is disrupted in all GBM. Radiation disrupts the blood-brain barrier. There's a lot of data, people talking about that, and because we're giving radiation to brain tumor patients, then maybe it doesn't matter. Even if the blood-brain barrier is intact, when we give the radiation, the blood-brain barrier dissolves, and so then we don't have an issue. And then finally, the overriding one is blood-brain barrier penetration is not important in GBM therapy. So first, let's just talk about, so the fundamental argument that the blood-brain barrier is disrupted is based on imaging, medical imaging, that tumors light up with contrast. And so is there a reason to think that that is a good marker of blood-brain barrier disruption? So the contrast that we're talking about is gadolinium. It's a highly lipophilic or highly hydrophilic compound that can't diffuse across lipid bilayers and can only get through if there's a disruption of the tight junctions between the capillary endothelial cells. So if this is physically leaky, then gadolinium can get out into the surrounding tissue. And so we're going to just talk about this in the context of these four issues that I have up on the screen here. So first, just thinking about disruption of the blood-brain barrier. This was work that we did with Natalie, where we took animals with intracranial brain tumors, and we gave them both Gatavist, which is the MRI contrast agent, and a drug, SAR-405838, which is an inhibitor of MDM2. And we looked both at drug distribution by Gatavist, by using MALDI-MSI spec, as well as using MRI here with a 7 Tesla magnet. And in GBM 108, which is just a tumor that doesn't respond very well to this drug, there's relatively poor Gatavist uptake, even though we could image it on MRI. Now this is a 7 Tesla MRI. We don't image patients with 7 Tesla. We image them with 3 Tesla. But nonetheless, the contrast is pretty evident. But very poor drug uptake and very poor gadolinium uptake. And so what we wanted to do is test whether if we artificially disrupt the blood-brain barrier, would we improve drug delivery and would we improve gadolinium delivery? And so what we did is we took the same tumor and we just overexpressed VEGFA. So VEGFA is known to promote a leaky, immature vasculature. And that resulted in increased gadolinium accumulation in the mouse, as well as improved drug delivery, and a little bit more brighter T1 contrast image. But still, I think that the take-home message is that at least at 7 Tesla, you can see a very faint amount of gadolinium. You can see just fine on MRI, and this makes sense. I mean, you don't have to have gadolinium is an MRI. I mean, this compound was designed to light up with MRI. So you don't need a ton of it in the tissue in order for it to light up. And so the take-home message here is that a little bit of contrast is enough to see it on MRI. So just because a lesion is contrast enhancing doesn't mean that you have a completely disrupted blood-brain barrier. It means that you have a little bit of contrast in the tissue that's enough to see it on MRI. So there's also, there's a ton of surgical data, and some of it comes back to like the 80s with Patrick Kelly at Mayo Clinic is one of the classic studies, but there's multiple studies shown here in this. This doesn't work very. So there's multiple studies in this graph below, in the table below, that have basically looked at. They've done MRI, and then they've done image-guided biopsies of these different locations, either in the contrast-enhancing region or outside of the contrast-enhancing region, and look for where do we see tumor cells. And essentially, the summary here is that when they do this, 80 to 100% of the biopsies that extend outside of the contrast-enhancing region are positive for tumor cells. This is very different from brain metastasis. For brain metastasis, you have a focal lesion that's contrast-enhancing. Basically, if you just took that region out, half of the time you're going to cure that location with surgery alone. Whereas in glioblastoma or gliomas in general, you take out just the contrast-enhancing region, 100% of the time you will not cure those patients. And that's because these tumor cells infiltrate beyond the contrast-enhancing region. So even if you took at face value that the contrast-enhancing region is completely disrupted for blood-brain barrier, you still have a lot of tumor that's infiltrating beyond the contrast-enhancing region that we know is intact. There is no gadolinium, and yet we know there's tumor cells there. And so there's also an issue of just, and that's kind of what we're talking about a little bit, is the natural history of glioblastoma. You can take out the entire half of the brain. This was done back in the 40s, and the tumor comes back. So that's just kind of the natural history. And Bill likes to make a nice point of this, is that glioblastoma is a whole brain disease. The tumor cells are throughout the brain, even though we can only see them in the contrast-enhancing region and in the surrounding region. And so coming back to our lady who had this lesion here, it was completely resected. This little contrast enhancement here is just post-op changes, so that's a complete gross total resection. Well, her recurrence happened in the opposite hemisphere, came across the corpus callosum and in the opposite hemisphere. And so this is just kind of reflecting the natural history that these tumor cells are highly infiltrative, and her radiation field would have been all through here. So when we do radiation, we don't just do right here. We do a fairly broad region of normal tissue around that to try and take care of those infiltrating cells. And so that's just in a I'm not sure if this is the same lady or not, but basically kind of what we normally do is we outline the contrast-enhancing region, and then depending on the center, sometimes we outline the edema volume. I always contour the edema volume, and then we add a little bit of margin on that, and we're giving 60 gray in 6 weeks to that region, and then they get concurrent temozolomide and adjuvant temozolomide following that. And so one of the points here is that we're mapping not only contrast, but we're mapping outside of the contrast region. And still, the pattern of failure is there's about a reasonable fraction of patients, about 20% of patients that fail outside of our radiation field. So we're expanding well beyond the contrast-enhancing region, and yet a third of the patients, or almost a third of the patients, fail outside of that region. And as patients remain disease-free, as they go further and further out, the risk of having a new lesion that's outside of our radiation volume increases significantly. So if a patient survives beyond 2 years, over 2/3 of the time, they're going to fail outside of our original radiation volume. And then finally, just looking at amino acid imaging. So brain tumors, the blood-brain barrier actually facilitates transport of amino acids into the brain, because those are important for thinking and stuff like that. And so using a number of different radiotracers like FET or F-DOPA and C11-methionine. These are all small amino acids or amino acid-like molecules. We can see intense radiotracer uptake with F-DOPA in this example. That's quite a bit outside of the contrast enhancing region. There's really pretty faint contrast enhancement in this particular patient at this particular level, but really significant F-DOPA uptake. Just highlighting that tumor, and F-DOPA has been linked to tumor density. So just highlighting that there can be dense tumor that doesn't contrast enhance. And then MR spectroscopy, the same thing. We can use MR spectroscopy to detect signal for tumor versus normal and demonstrate that there's significant tumor that extends beyond the contrast enhancing region. And so, just to summarize, to just really kind of hammer the point, there's biopsies that demonstrate that tumor extends beyond the contrast enhancing region. There's PET and MR spectroscopy that demonstrate tumor that extends beyond the contrast enhancing region. And there's tumor progression outside of the contrast enhancing lesion. So, I think there's really no doubt in my, I think there's just no doubt that there's regions of GBM in every patient that extend beyond the contrast enhancing region, and that blood-brain barrier is intact in every patient with a glioblastoma. So I think that myth is pretty much busted. There's really no doubt that regions of GBM have intact blood-brain barrier. So now the question is, well, does radiation disrupt the blood-brain barrier? And as a radiation oncologist, this is very interesting to me. And I think part of the issue with radiation is that a lot of the preclinical studies are done with high doses of radiation, and they're done with imaging techniques to really measure disruption of the blood-brain barrier, as opposed to looking at how effectively do we effectively increase the drug levels when we give radiation. And so I think probably the best data for trying to understand what's happening in patients is patient data. And so there's a thing called pseudoprogression that happens in GBM. This is more common when we treat patients with radiation plus temozolomide. But basically what pseudoprogression is that we have a contrast-enhancing lesion that we treat with radiation. And then after we finish radiation, it starts looking much worse. And then it's not clear a lot of times in the clinic whether that's true progression, where the tumor is coming back, or whether the tumor just has gotten a little bit, maybe the therapy is highly effective and is really kind of disrupting the normal architecture of the tumor tissue, and you're seeing increased contrast enhancement, but clinically the patient is doing fine. And so that's called pseudoprogression, and this is just a graph looking at pseudoprogression where lesion 1, the green lesion, is the pseudoprogression lesion, and it basically stays contrast enhancing and really just goes a little bit down over time, and then the true lesions are progressing much later. And that's kind of what we're seeing here, that there's some pseudoprogression going on here. These are quiescent tumors, and then this tumor is really kind of fading away over a longer period of time, and then gradually starts coming back in this region here and this region over here. And so this phenomenon of pseudoprogression happens in up to 30% of patients with GBM, but the issue is that it doesn't happen during radiation. It happens after radiation typically, and it can happen up to 6 months after radiation. So I think that this clinical data would suggest that, yes, again, contrast enhancement equals at least partial disruption of the blood-brain barrier, and about a third of the time this happens. A third of the time, patients that are treated with radiation do see increased contrast enhancement, do have some pseudoprogression, but it's not reliable. Number one, we don't know whether it's enough to change the drug delivery. We know it's enough to change gadolinium delivery. And number two, it's not reliable as far as when it happens. It's not necessarily happening during radiation. It may or may not happen in the future. So to try and develop a drug delivery strategy around radiation doesn't really necessarily make sense. But to really kind of try and test this in an animal model, we worked with Bill to look at drug delivery of 2 different molecules. These are both PI3 kinase mTOR inhibitors developed by Genentech. GDC0980 is in clinical development, and that's a brain impenetrant drug. The company is well aware of that. And they developed a very similar compound, GNE317, that is highly brain penetrant. And so the idea was that we could take mice and just irradiate half the brain and then treat them with the brain penetrant and the impenetrant drug at the same time. And the idea would be that the irradiated brain and the unirradiated brain would serve as their own controls. And with the brain penetrant drug, we should see equal levels on both sides. And with the brain impenetrant drug, we should only see drug on the irradiated side. That was the general idea. Just looking at the graph, the left side is unirradiated, right side is irradiated in white, and there's just no difference in the drug levels between the unirradiated and the irradiated side in either of 2 for either GNE317 or GDC0980. So radiation really had no impact on the delivery of this brain impenetrant drug. And we used 2 different regimens. One was 4 gray times 10. This is a clinically relevant radiation regimen that we use for re-irradiation. If someone's failed radiation, we might re-irradiate them, and this is a common regimen we use. Then we also used 40 gray times in a single fraction. This is a dose of radiation that you would never use in a human. It would just really cause catastrophic problems. And that's why we only kept these mice alive for 2.5 days, because we didn't really want catastrophic problems with our mice. But again, there was just no impact on drug delivery. Again, we did not look at contrast enhancement, and my guess is that if we gave 40 gray in a single fraction, we probably would see changes in contrast enhancement. In these studies, we haven't published. We're still kind of debating how we want to develop this story. But again, I think we have both clinical data as well as pharmacologic data that radiation really doesn't have a reliable impact on drug delivery in the context of really thinking about how we treat patients. I think there is this data of pseudoprogression. There's changes in contrast enhancement. And so that's kind of why it's plausible that radiation is having some impact on blood-brain barrier. But from a pharmacologic strategy, I don't think it's really where we need to go. So the final question, really to kind of bring this back all together, is like, does it matter? Do we really need to focus on blood-brain barrier, delivery of drugs across the blood-brain barrier when we think about developing drugs to treat patients? Because the ultimate goal is to cure GBM, and will we be able to cure GBM if we don't think about the blood-brain barrier? I think you know where I'm going with this, but I'll now give you some data to bring it home. So this is a fundamentally really important question, right? Because every major medical center in the US has this goal here. Take a tumor, stuff it through a sequencer or a mass spec or something, get an answer out that tells us, treat with this drug. And in that paradigm, if you're not sure that the drug will get to the target, you might have a failed strategy, not because the sequencer's wrong or the predictive algorithms are wrong, but because you're not using the right drug. And if 98% of the drugs that we have available don't penetrate the blood-brain barrier, this is a huge issue for GBM, in that large efforts to try and develop individualized medicine strategies for GBM might fail just because we don't pay attention to simple things like getting the drug to the target. And so that's really the underlying basis for why we applied for our U54, and I think why we got it funded was kind of this issue. Like, this is a pretty fundamentally important issue to think about if we're trying to try and cure GBM. So again, we've talked about this already. And so now I'm going to give you a couple anecdotes of drugs that we've tested in animals that look pretty promising but don't particularly work well. So let's talk about a couple of these. So Wee1 is the first one. This is Wee1 is a kinase that phosphorylates where's my CDC2 on tyrosine 15 and threonine 14, or I guess it's just tyrosine 15, and that triggers a G2 arrest that prevents cells with DNA damage to progress through mitosis. This is thought to be quite important for DNA damage recovery, and so there's a strong interest at the NCI for developing this drug as a radiosensitizer or as a chemosensitizer in GBM. And so to start looking at this, we have a panel of patient-derived xenograft models. So these are tumors that are taken from the OR, put in the flank of mice, grown in the flank of mice. They never touch plastic. Then we put them into, we can either do cell culture work like we did here, or we can put them into the brains of mice and treat them like we would patients. And so this is just a Western blot across our panel of flank tumors, looking at Wee1 expression, and we just selected two that I'm going to be showing more about, GBM6 and GBM22. 22 has very low Wee1 expression, 6 has higher levels. But when we look in vitro, GBM22 is more sensitive to single agent Wee1 inhibitor, 1775. We see an increased S phase arrest, and we see pan-nuclear H2AX full. So these are all consistent with the role of Wee1, also not only in G2 but also in S phase. And then just looking at DNA damage signaling, if we treat with temozolomide, with or without 1775 and GBM6, we really don't see a whole lot of signal. GBM6 happens to be inherently resistant to temozolomide, so it's not surprising that we don't see a signal with temozolomide only. In GBM22, which is inherently sensitive to temozolomide, we can see, it's interesting, number one, CAP1 is a substrate for ATM, ATR, DNA PK. It's a fairly sensitive marker for DNA damage signaling. And so we see phospho-CAP1 just with 1775 alone, with temozolomide alone, and with the combination we might see even more. And I'm not convinced that this looks like it's a Western artifact. So we're seeing nice suppression of CDC2 phosphorylation, CDK1 phosphorylation. When we treat with 1775, we see loss of that signal, barring the Western mishap there. And so this was an interesting strategy. There was a rationale to pursue combinations of temozolomide with 1775. And so in GBM22, in the flank, when we treat with temozolomide alone, it's quite sensitive to temozolomide. Here's placebo and 1775 alone. Temozolomide alone, we see nice sensitivity. And when we combine 1775 with temozolomide, we see almost a doubling in the median survival that we see with drug therapy. I mean, that's a pretty impressive benefit. But when we do the same tumor in the brain, we don't see any benefit. There could be a number of reasons for that. I mean, there's a difference in the brain microenvironment could affect signaling, things like that. But DNA damage is kind of fundamental to the cell, and so I guess I'm not totally convinced that microenvironment's that important as far as how the tumor cells behave. But we did look at the brain to plasma ratio, and there's basically 5% of the drug gets into the intact normal brain. And so we were wondering, gee, could it be that it's really drug delivery into the brain that limits the efficacy? And so this was work that we did with Natalie, just looking at the flank tumor versus orthotopic tumor, and using MALDI-MSI spec to look at 1775 drug levels, and then red is for heme as a marker for vasculature. And you can see in the flank tumor, we see nice, relatively homogeneous drug delivery into the flank tumor. But in the orthotopic tumor, these are all the same section. Here's the tumor itself. We see very faint drug uptake in the tumor itself, suggesting that, this could be a fundamental reason why 1775 didn't work in the brain, but worked in the flank. So are there other examples that we can talk about that are similar to this? So CDK4 inhibitors are also quite interesting. They're FDA approved for treatment in breast cancer. And there's deregulation in glioblastoma that happens quite frequently in the RB signaling pathway. And some of that is related to some of the deletion of like P16, amplification of CDK4, CDK6, and relatively infrequent mutation of RB. So this is a rational strategy to pursue in glioblastoma. And again, kind of looking at some of the things that are kind of interesting. We looked at CDK4 amplification. GBM63 is CDK4 amplified. And so one might expect just from stuff through a sequencer and get out the results that CDK4 amplified should be sensitive to CDK4 inhibitor. You know, just in the context of if you're addicted to CDK4, then inhibiting CDK4 should work really well. But that's actually the opposite of what we found. GBM63, shown here, is quite resistant to CDK4 inhibitor. This is the Pfizer drug, which is called palbociclib. That's FDA approved. Whereas GBM6 is quite sensitive, which is not CDK4 amplified. So just number one, I think there's a reason to do animal studies or cell culture studies to try and understand what we think we know. Is that really what we really know? And again, kind of here's the same GBM6 and GBM22 panel, just looking at P16. They're both P16 deleted. And it's interesting that CDK4 levels there's a single copy deletion in GBM22, so it has relatively low levels of CDK4, single copy deletion of CDK4, relatively low levels by Western in GBM22. And even though GBM6 in that previous slide I showed you was quite sensitive in vitro, in vivo it's relatively resistant. This is flank tumors, true with palbociclib or placebo, and there's really no difference. Whereas in GBM22 we see a pretty profound benefit of the CDK4 inhibitor compared to placebo. But again, it's kind of same story. When we treat a flank tumor, we see really great benefit compared to placebo. But in an intracranial model, we don't see any benefit whatsoever. And really, work done by Karen Parrish in Bill's lab has really demonstrated that palbociclib has very poor brain penetration. Here's the wild-type mice. And just looking at concentrations of drug in plasma versus brain, there's about a 10-fold difference in drug levels. But if you look at efflux transporter defective mice, then the brain levels go much higher, demonstrating that this is probably an efflux-mediated process that's limiting drug delivery into the brain. And so finally, I'm going to end with this story about MDM2. So MDM2 is part of the p53 pathway. It's modulates degradation of p53, and so amplification of MDM2 would be essentially the equivalent of a p53 null tumor. MDM2 amplification happens about 15% of tumors. And so we took our panel of GBMs and we did both genomic, just straight PCR to look for MDM2 amplification, as well as RT-PCR to look for gene expression number. And so we're going to focus on GBM102 and 108. Both are MDM2 amplified, but 102 has low expression of MDM2, and GBM108 has high expression of MDM2 at the RNA level. And so just looking, so we're going to use two other lines, GBM10 and 12. 12 is mutant for p53, so we'd expect that an MDM2 inhibitor wouldn't work in that context, because if p53 is already mutant, then who cares about the ubiquitin ligase that degrades p53? And GBM10, that's wild type for p53, but not amplified. And so you can see here, just looking at apoptosis at 24 and 72 hours, GBM108 is the only line that's quite sensitive to this MDM2 inhibitor. This is the inhibitor from Sanofi, whereas 102, which is amplified but doesn't have high-level transcript, is resistant. This is not really particularly surprising. This is kind of what we would expect. And in the flank, again, 102, amplified but not expressing MDM2 is quite resistant to the drug, whereas GBM108, we see this is a pretty awesome effect for a drug in mouse models. If you're seeing a tripling in survival, that's kind of what we see with temozolomide. So in my world as an animal guy, if we're seeing an effect that's similar to what we see with temozolomide, and temozolomide is FDA approved for a significant benefit for patients, this is a drug that, in my estimation, would be significantly beneficial for a patient. this would be worth taking forward into the clinic. But unfortunately, not to be a broken record, the intracranial tumors, so in this particular experiment, these are the same cells out of the same mouse injected into the brain and injected into the flank and then treated identically. So this is not like a possibility that there's a mix-up in the cell lines or that they've diverged or anything like that. This is the exact same experiment, essentially. And here we see really significant benefit from the SAR, but no benefit in the intracranial, but just benefit in the flank tumors. So to really kind of get at this question of, is it microenvironment that's affecting how the cells respond to a drug if they're grown in the brain versus the flank, or is it drug delivery? This is where we came to this VEGF overexpression system that I talked about before, where we took GBM108 cells, we expressed either empty vector or VEGF-A, and we can see much better drug delivery in the VEGF-A overexpressing cells. And so then at the same time, if we put these mice into a survival study, again, orthotopic tumors, empty vector, the drug is having a nominal effect on survival, but in the VEGF-A overexpressing cells that have higher drug delivery, we see a much better drug efficacy, despite these tumors being more aggressive. The placebo mice are dying under 30 days, probably your median survival, whereas here it's about 40 days. So again, I think this is probably the best evidence that we have from our lab, our collective center, that would suggest that drug delivery really matters. If you have poor drug delivery into a tumor, it's going to be a problem. And again, this is somewhat intuitive. I mean, this is somewhat like no duh. This is what you should see, right? Getting back to like the 1775 story, the MK1775 story, despite our data saying that there's poor drug delivery into the brain and poor efficacy in brain tumors, this drug was moved forward by the NCI into phase 1 testing, and now there's consideration to move this into phase 2 and phase 3 testing, despite the data that we're presenting. So it may be a no duh, but there's a machine that you need to kind of convince otherwise. And so I think one of the rationale for doing the no duh science is that not everybody sees it that way, and really trying to convince the people that matter, which would be the scientists that are taking these drugs forward into clinical trials. Because if we're taking drugs into clinical trials where we think there's no chance of the drug working, then we're exposing patients to risk without a chance of benefit. So that's fundamentally why the stuff that we're doing, I think, is important to do. So not only do we have these 3 examples that I've shown you, but there's a number of other studies that we have ongoing in the center that are looking at multiple drugs that have similar issues where delivery seems to be a fundamental problem. So I think kind of if I can leave you with anything, this would be the slide I want you to remember, that the blood-brain barrier matters, and understanding how well drugs penetrate into the brain is a critical issue that we need to address. And kind of just to leave you with one thing, as a radiation oncologist, my training is either treat the whole tumor or don't treat. There's no way that I would see a patient with lung cancer and say, well, this side is easy to treat, but this side's not so easy, so we're just going to treat this side, and hopefully that'll be enough. I mean, we just don't do that. The idea is that either you treat the whole thing or go home and don't treat. And so we're thinking, and in the context of brain tumors, we're treating the bulk tumor that we can see, and that's deriving patients some benefit. But for drugs, we need to think a little bit broader. I mean, for radiation, we can't treat the whole brain to 60 gray in 6 weeks. People don't appreciate that. They don't, there's a lot of toxicity associated with that. But drugs that can penetrate into the brain, that's what we should be looking to do. We should be looking to treat the entire brain with these drugs that are highly effective so that we can try and cure these patients. And I'm going to skip that. So anyways, I'd be happy to take any questions.
Questions?
Yeah.
Actually, sorry, can you use the mic because we're actually recording, so we can put it on the web for our education outreach.
Thank you very much for a great talk. You've shown that mice that were deficient in some transporter, and efflux transporters in particular, had a much better brain uptake of some of the drugs. Have scientists tried to use this and to study the transporters themselves to maybe add a moiety that would make the drugs stay in the brain and not be transported back out into the bloodstream, or the other way around, just be uptaken more efficiently?
I think I'm going to defer that question to Bill's talk. Is that fair, Bill?
That's fair.
I think he'll cover that.
Scientists have tried to do that. If you're going to be here, otherwise we talk later.
Yeah, the question is that I have is, what happens with the blood-brain barrier in the prospect of cellular immunotherapies that are appearing now?
Right. No, that's a great question, and I think the jury's still out. Right now, the clinical data suggests that immune checkpoint inhibitor therapy is not particularly working well in GBM in the early studies, and it's not clear. Number one, this is somewhat a tangential answer to your question. It's not clear why the immune checkpoint therapies are not working that great. One possibility is that there's difficulty in brain penetration, and it kind of depends on the inhibitor that you're using. So a PD, I always got to make sure I get this right. I think the PD-L1 is on the tumor cells, and so there it's important that that antibody can penetrate to the tumor cells where the immune cells might be. And so there you might expect to be more of a drug delivery issue, whereas the PD-1, which is on the T cells, presumably the antibody can engage those T cells before they invade into the brain. So there's, I think historically there's been this myth that the brain is an immune sanctuary and that immune cells don't get in. I think that, there's more data suggesting that there is immune trafficking into the brain, and that in GBM you can have a pretty high fraction of tumor cells, cellular content that's immune, that are immune cells. And so, I think that immune cells probably effectively traffic into GBMs, but whether the drugs that we're trying to target actually do is a different question.
Other questions? So I have a dumb question. It's such a, to me at least, it's such a no-duh thing that you have to get drugs into the tumor in order for the drugs to be efficacious, right? And especially in brain tumors, with the blood-brain barrier. So why haven't more companies developed brain-penetrant drugs, and what's the big issue here?
I mean, I think there's probably two big issues. One is that some drug companies design drugs specifically to be excluded from the brain because they're worried about neurotoxicity. And so, one way to avoid neurotoxicity is make sure your drug doesn't get in. And they may not be intentionally designing it, but they're not designing it specifically to get in because you open yourself up to more toxicities. And then, at least for GBM, the market is very small. I mean, GBM is an orphan disease. There's 14,000 cases a year. So compared to breast cancer, which is, 150 or something like that, or 200, there's a vastly different market potential. That doesn't necessarily remove all the players from it, but I think that's part of the issue. If you take a broader view, though, that brain metastases also are important, there's 100 to 200,000 brain metastases a year. And so that changes the market equation quite a bit. And I think that's part of the interest. From my perspective, we have some brain metastasis models as well. And so trying to convince drug companies to change how they design drugs is probably easier if you use a brain metastasis model than a GBM model. For example, HER2-amplified breast cancer has a high propensity for brain metastasis. And it's not clear whether that's the biology of the tumor or whether it's because the fundamental therapy for HER2-targeted breast cancer is an antibody or an antibody drug conjugate that doesn't get into the brain. And so if you control the systemic disease adequately enough, then you start seeing brain metastasis later. And the same thing could happen with melanoma. As we have better and better drug therapies for melanoma, we control the systemic disease, and then we start seeing the natural history of brain metastasis for these tumors. And so I guess that would be, the prediction as we get better effective systemic therapies for brain metastasis. And that might change, and it appears to be changing some of the thinking by some of the big companies like Genentech.
Thank you. Very nice talk. And, thank you. I'm Tom Byrne. I'm a clinical neuro-oncologist and have been at this for a very long time. I trained with Terry Casino at Memorial a long time ago. Cool. So I've been watching this for a very long time. And back in the 1960s and 70s, the NCI decided the blood-brain barrier was the problem with gliomas, and they developed ultimately PCNU, which has the optimal partition coefficient, and it didn't work. And Ed Newell subsequently and others have tried to open the blood-brain barrier, and they don't work. One thing, I don't want to saddle you with this question, but hopefully others will talk about it, is heterogeneity.
Yeah.
And I think, there are lots of clinical examples of brain metastases that respond to treatment, systemic treatment. Lymphoma is probably the best example. Chemotherapy is marvelous with lymphoma. And I think one of the major Achilles heels in glioma, which has not been recognized, and unfortunately for the young folks in the audience, I think to pay attention to, because we've repeated a lot of history. You mentioned doing hemispherectomies. Well, actually, they were done 100 years ago by Harvey Cushing, and he abandoned it because it didn't work. And there's a long, long literature on that, and a lot of people kind of have focused on this contrast enhancement, which largely came out of Fred Hochberg's work at the MGH. About 1980, he published a paper. I won't go through that. But I think the heterogeneity problem is a reason that gliomas don't respond, a major reason. And targeted therapy just doesn't make any sense with gliomas, glioblastoma, because it's whack-a-mole. And you may get an initial response, but then you have this, So basically, if you think about clinical cancers, essentially all clinical cancers, not everyone, but almost all, respond to multi-agent chemotherapy. Those that respond, like leukemia, lymphoma, respond to multi-agent therapy. So I wish more people would focus on the heterogeneity of these tumors, although the current gospel is targeted therapy is the way to find the solution. It is for some tumors, but this is the heterogeneity which was talked about in the 1980s needs to come back into the forefront and recognize that it's not a single gene. There are multiple different cancers in every glioblastoma that have multiple different pathways. I hope some of the other speakers will address that.
I don't know, but maybe you
you
could
for
hand
your
the mic to Jann. Put Jann on the spot here.
Yeah, our lab and at Mayo, we do study heterogeneity in GBM, and this is a great point. I think that's actually it's important in terms of targeted therapy and drug response, because we don't see, in terms of, we do a lot of image-guided biopsy and taking different regions of the tumors and assessing their genomic analysis, kind of more at the mutation level, and basically show that there are certain regions of these tumor cells that have certain specific alterations that targeted therapy would not touch. And so we are addressing that.
Yeah, I don't think we could agree more, because the two issues I think we believe is the heterogeneity and the delivery. And the two can't be taken away from one another, because one of the things that we're considering is, intelligent combination therapy. Anytime you mention combination therapy in oncology, you get issues, but it works. Toxicity is the major consideration. And so if we can find, and I'll show examples of PI3K, MEK, and BRAF as a combination therapy, and thinking about then the delivery of all three of these, so we don't play into the heterogeneity and get resistance because we have the wrong combination, or one of our drugs doesn't make it in and the others do, which would be a problem. So, you know, we liken this to the advances made in AIDS, neuro AIDS, and you know, it was combination therapy at that point that really made a difference.